Apology, please.
Sorry about the delay. I'm just going to quickly introduce Dr. van Staden. He completed his medical degree at the University of the Witwatersrand and went on to do his internship at the renowned Groote Schuur Hospital in Cape Town. Dr. van Staden completed his community service in Limpopo, where he worked primarily in the emergency centre and family medicine, gaining a broad and intensive experience in acute care in a rural setting. Since 2023, he has been practicing at Mediclinic Midstream Emergency Centre, where he continues to apply his skills in a high-paced critical care environment. In 2024, he earned his diploma in primary emergency care, further cementing his expertise in the field. Known for his calm approach under pressure and commitment to patient-centered care, Dr. van Staden is passionate about advancing emergency medicine practice, particularly in assessment of traumatic brain injury. So he's going to be talking about that today.
All right, thanks very much for the introduction. Yeah, sorry for the delays, guys, but today I'm going to be speaking about head injuries, more focusing on the mild head injuries and concussions as the emergency room and first visits. It's something that we do see quite commonly. It's one of the more common causes of trauma and reasons for people seeking care in the emergency units. I will touch on the severe and moderate injuries later down the line, but the focus is more going to be on more conservative management, when to image the patients, how to counsel the family, and then later the return to sports and concussions for the patients. It is, yeah, as I said, quite a common thing that we do get referrals for, especially from outside. For essentially people are referring to us to get CT scans done, but there's no clinical reason for them to have the CT scan done. And we end up then just having to tell the patient to go back and monitor and observe, which just leads to a little bit of frustration for the patients, potentially over imaging if they do or do insist on getting the CT scan because that's what they're referred for. So, as I said, yeah, it's quite a common visit to the emergency units. We get these injuries, they can occur at all ages, but you get these spikes depending on different age groups. So between your 0 to 5 years is when they start getting the accidental injuries. So let's say just be aware of those if they are coming more frequently. If there's any signs of non-accidental injury, you must just remember to look out for the signs and get the social workers or police involved if you are concerned. Then the young adults, when they start driving, starts to participating in contact sports and high-risk sports, their incidence of traumatic brain injuries goes up. And then above 65, when accidental falls start occurring. The NIH said that traumatic brain injuries were 25% of non-natural deaths in South Africa in 2013. So it is quite a significant finding. And apparently pre-hospitally, about 90% of pre-hospital deaths can be attributed to brain injuries. So it can be quite significant and severe. Just the graphs on the right, the top one's just showing the incidence of traumatic brain injuries by age, just seeing that spike there around the 21 to 30 years old. And then the lower one is just showing the severity, so the admission rates for head injuries and in-hospital death rates starting to go up from age 65. So that's why when you get later to the scan criteria, anybody above age 65 will be classified as high risk. So incidence, there's about 200 per thousand in the developed countries, and then roughly about 2.5 million cases of traumatic brain injuries in America per year. The prevalence of people living with a traumatic brain injury or some deficit or symptom of that is about 55 million. South Africa, we have an incidence of 316 per 100,000, but it's likely underreported as people often don't seek care for mild injuries or they just try and manage it by themselves. Males are more likely than females just due to the risk-seeking behaviors. Accidents are the most common cause, and usually about 75% of the traumatic brain injuries are classified as mild, with about 10 to 5% for the moderates and 5% for the severe. In our country, motor vehicle accidents are generally the most common, and then it's falls and then assault as our third most common. But it can be a significant cause of morbidity long term. If you have repeated brain injuries or severe brain injuries, you can have cognitive changes, post-traumatic epilepsy, or neurological deficits. So just for the anatomy, so We start out with our skin and dense connective tissue on the outside, then the aponeurosis, loose area of the connective tissue in the periosteum. If there's no skull fractures or no open wounds, the bleeding is going to be limited to in these structures, tamponades quite easily. So you don't generally lose lots of blood from the head unless there's an open wound or an open artery that's been cut. Parents will often be quite concerned with this hematoma on the head. You can just counsel them that it will resolve slowly. You just need some conservative care if that is the only injury. Then for our spaces, on the outside, we've got the dura mater, then just before that's your subdural space, then your arachnoid mater and your pia mater. That's where your bleeds will go depending on which structures are injured, and then depending on which space is involved, that will give us the typical findings on the CT scans as needed. So intracranial pressure is one of the important things when dealing with traumatic brain injuries. Just on the right is the Monroe-Kelly doctrine showing that the brain is a fixed volume. You can't really displace your brain matter. So what buffers is your CSF and your venous blood. So if you do have a bleed, it starts to slowly shift out, and with vasoconstriction and shunting of the CSF, you can tolerate some changes, but then to a point where your buffer capacity has been reached, you get a rapidly increasing intracerebral pressure there to the right, and that's where you get some herniation, which is starting to be your endpoint and more severe side of a head injury. So importantly, start everything with your history for the patient. Right, is just some red flags just to look out for. If there are any of these, treat it more carefully and explore it a little bit more, but importantly, you just need to think about the time of the injury, the mechanism, if there was any sort of change of symptoms straight after the impact versus where they are with you now. Any sort of amnesia, either retrograde or retrograde amnesia, will be important as well. Because often when they get through to you, there might be GCS 15, but just explore around what they can remember around the accident, what they can remember after the accident or the injury, and then just take it from there. Just remember, head injury often is just a symptom, especially when we start getting to the above 65s. You need to start reviewing the cause, because you'll often find that a patient is coming through for multiple falls in a short amount of time, and you need to explore just, was this maybe a syncopal episode? Are they starting to get seizures? Is there anything else that's maybe causing them to fall? So don't just do the scan if it's normal, send them home if it's now been a good few times of them falling and causing injuries, because each one can be significant. So our goal of care is essentially to prevent the secondary brain injury. We can't go back and take away the impact. So what we need to try and do is just to try and ideally maintain a physiological norm to reduce the metabolic demand of the brain so that you can try and prevent any further secondary issues. So we do that by maintaining oxygenation, avoiding hypertension is one of your big things, airway maintenance, and then correcting any deficits that you have. As you see on the right there, your secondary injuries is due to your changes in your pressure, hypoxia, hypertension, hypothermia, electrolyte abnormalities. So if you can try and correct what's wrong, get them back to the physiological normal, you can try and prevent as much of the secondary injury as you can. So this is a few things of when we actually need to do a CT scan for a patient. So on the left, we've got the PECON pediatric rules. So they're split nicely between 2 years and older than 2 years, but essentially it's if there's any altered mental states, if the GCS is less than 15 at the time of examination, or if you've got a skull fracture, you need to do a CT scan. The more moderate signs for the younger than 2 years, if there was a loss of consciousness more than 5 seconds, but they get back to you and the GCS 15 alert play for maybe a little bit irritable, you can potentially observe them. Non-frontal hematomas not acting normally or severe mechanism, you can observe rather than discharge, rather than CT scan straight away. If they've got no symptoms, you can just counsel and say the risks using this is less than 1% for a severe brain injury. The same thing for the above 2. The only thing is the history of vomiting, severe headache, and then the severe mechanism as well. And you see the severe mechanisms there at the bottom. It's a pedestrian vehicle accidents, unrestrained drivers, high velocity or high severity impact of a car was flipped, an accident with no helmets, or a fall from 3 height, or significant object landing on their head. Then for the adults, you can use the Canadian CT score. And this, they say that it's high risk if you have a GCS less than 15 more than 2 hours after the injury. So if they come through and they're GCS 15 in the EC, you can monitor them for up to 2 hours. And if there's no other changes in signs, you can then just observe. Any open or depressed skull fractures, any signs of a basilar skull fracture, more vomiting, the 2 episodes, and here's where the age more than 65 comes through. They all classify as high risk. Your medium risk is if you've got the amnesia, so the retrograde amnesia of 30 minutes before the accident or dangerous mechanism. You can consider the CT scans. If they're GCS 15, you can chat about maybe an admission for observations to see if needed, but you can get further advice and guidance on that. Just with the kids, when you are discharging or if you are wanting to observe, it doesn't have to be inpatient observations. If they don't have any symptoms, there wasn't significant mechanisms and nothing else too concerning, a competent caregiver is just needed to do the observation. So if the family are willing, they are able to look after the child and they stay within a reasonable distance to the health facility, you can safely discharge them to come back at a later stage if needed. So just to quickly talk on the risks of CT scans, because it is, now that it is a more readily available resource, our number of scans are increasing annually as more and more people have access to them. In America, they found that CT scans accounted for 24% of all radiation exposure to patients. There was a study done in 2009 that looked at quite 30,000 patients over 22 years. Total risk of their CT scans for cancer increased by about 0.7%. It increased from 2.7 to 12% when the patient was having multiple scans, but this was for more cancer follow-ups and cancer treatments. And the patient who had a 12% increased risk, I think, had about 38 scans in total. So there are risks, but it's also to the benefits of ruling out intracranial pathology can be decided on. But it's just more that you can counsel the parents that a CT scan is not a risk-free procedure. It does increase a bit of the radiation exposure. There was one projected risk model that they said in the future, CT scans could potentially be the cause for up to 5% of new cancer diagnoses. That was using a risk model with kind of the highest prevalence and risks attributed to CT scans. But if you think about it, then 95% of cancer is still caused by other causes, lifestyle factors, other risk factors. So yeah, it's a useful tool just to be aware that there are some risks. And usually in your children, you do want to try avoid scanning them multiple times just because the radiation exposure does worsen with children and go up over the years. So CT head, the dosage they use is millisieverts. It's equivalent to about 2 of those dosages. An X-ray is about 0.1. So a CT scan of the head is about 20 X-rays. Your CTC spine is about 60 X-rays, and they say it's about 8 months to 2 years of your background radiation. Yeah, the background radiation is roughly around that, but people working in radiation exposures with nuclear reactors and all of that, their companies keep them at about a 20 millisieverts per year over a 5-year average. So one CT scan is not going to be a major cause for concern. It's not going to give the patient cancer, but it is just a risk factor, just to be aware of. Sports injuries, rugby season is when we get quite busy. We often get people coming in with mobilized fully on spine boards, neck blocks and everything for the patients coming through because there was quite a bad tackle or injury on the field, and they come through to us for further immobilization. We always need to treat it as severe until we prove otherwise, whether or not that's clinically or whether it is with X-rays or CT scan is then for you to decide. So on the right, it's our C-spine imaging. So obviously if there's GCS 9 to 14, you can consider your X-rays. But just beware if there's any distracting injuries, but that's again based on your C-spine X-ray. If there's midline tenderness, pain on moving the head or anything like that, so just keep them immobilized if they are there. If there's a significant injury of GCS lower than 14, you can probably consider a CT scan, because the argument is how can you clinically examine a C-spine if the patient is disorientated and can't actively give you a proper response. But yeah, you can consider X-rays first if they're immobilized and it's quick to do the X-rays and not going to delay anything further. But if it's severe GCS less than responsive, you're most likely going to be doing a CT brain and C-spine just to make sure that there's nothing there before you start moving the patient or doing any interventions. But if they're GCS 15, their pain's not too bad, no midline tenderness, and you can slowly try and mobilize the neck, get them out of their head blocks, and then continue the further consultation. So the severity of injury is classified between mild, moderate, and severe. The GCS on the right, the GCS was made for traumatic brain injuries. So this is where the adage of GCS less than 8, you intubate. This is where it was made and studied, and the studies were all about this. So your mild is if there was an unconsciousness less than 30 minutes. I know a lot of people think that any loss of consciousness puts them more as a moderate to severe. But if it was just a short loss of consciousness, they come back through to you and they GCS 13 to 15 with no sort of traumatic amnesia for less than 24 hours would be classified as mild. Generally, in this case, if the patient is still GCS 13 or 14 and they do have amnesias, you would probably still err on the side of caution with scans and observations. But it just does show that it encompasses from GCS 15 down to 13 for moderate, mild. Your moderates is when your GCS starts dropping quite a bit more between your 9 and 12. Their level of unconsciousness was more than 30 minutes, but less than 24 hours. Post-traumatic amnesia, 1 to 7 days. Your severe traumatic brain injuries based on your GCS essentially is less than 8, but their unconsciousness level can last, or duration can be more than 24 hours, and they can have this amnesia for more than 7 days. So this is when we do get to the CT scan, just the different sites of the bleeds. So you've got your intraparenchymal, usually if there's blood pressure or trauma or bleeds inside the brain. Acute onsets of it, usually it can be arterial or a venous injury. Intraventricular, also arterial or venous, conforms to the shape that it's in. These ones are less common. Your more common ones are usually your subdural or your epidurals. The subarachnoid is a little bit more difficult to see. So it takes up the spaces there. You can get that wine glass appearance there at the basal cistern at the bottom. More likely to be arterial bleeds. It goes along your sulci and your fissures. So you might not see, but all of these bleeds can be associated with others. So you can have more than just the one. The subdurals, what we see quite often, your traumas lead to it. It's your venous injuries. So you can have a normal CT scan and later the subdural bleed pops up. That's where they get that typical thunderclap headache onset, sudden severe headache, and can slowly go through. So this is why if somebody does return with worsening symptoms, you do potentially need to rescan them. The epidurals on the outside, usually an arterial bleed, usually quite an acute onset, and they might have this period of lucidity, and then the GCS starts decreasing as well after the injury. So your moderate to severes, you are going to be getting a neurosurgical consultation for further care. Airway management is going to be quite important, especially if the GCS is either deteriorating or when they get to you, if it's less than 8, they do need to be intubated and on neuroprotective ventilation. When you are intubating, you want to make sure that you have your highest first pass success rates. Think about something like fentanyl to blunt your intubation response because you don't want spikes in blood pressures or sympathetic response. Drugs generally use etomidate or rocuronium, or with rocuronium, and I think ketamine has also been found to be quite stable for head injuries in trauma settings. Then after that, you want to be preventing hypotension. If the patient is hypotensive, the intracerebral bleeds are generally not the cause. If they are hypertensive, you need to go and look to find what's causing it, or if they're bleeding anywhere else. Because if there is a severe or moderate head injury, it's usually not just an isolated head injury. Depending on the mechanism, you need to be thinking about maybe doing pan scans or EFAST or other imaging just to see where else is the bleeding or the injuries can occur. So for the hypertension, you're just targeting a systolic blood pressure of 100 millimeters of mercury for ages 50 to 69. And then for your ages 15 to 14, 110 BP of systolics, and for your ages above 70. Your PaCO2, you want to be just targeting a normal carbon dioxide, more on the lower side of normal, targeting 35 to 40 ideally. You don't want to be going to hyperventilating the first 24 hours. It can be used as a mechanism to try and reduce intracerebral pressure, but ideally not in the first 24 hours and used more at a later stage as like a rescue device rather than anything that we're going to be targeting the emergency room. Saturations, normal, more than 95%, PaO2 of 100. So if you are intubating them, just target your FiO2 according to that. You don't want to be putting much higher oxygen levels. There's no real benefit. So with medications, just be careful with your sedatives and your analgesia. You don't want to be giving anything that will now further worsen a GCS, and now you're not sure if it is a change in the symptoms from the injury or if it's now from the medication that you've been given. So their recommendation is low dose, short acting, easily reversible medications. So your opioids, your short actings, your fentanyls, if needed for severe pain. If there are other injuries, Pafalgan's generally a great bet to use as well. But a little known thing is that one of the preservatives in Pafalgan is mannitol as well. So that's why sometimes people find it's very helpful for a headache, as the small amount of mannitol can have a bit of an effect, but it's not going to be your loading dose that you're going to be giving if needed. Fluid choice, normal saline or ringers for resus. Your sodium levels are something that you're just going to be needing to watch, because at later stages, you can see hypertonic saline can potentially be used for intracranial pressure, where it doesn't have an effect on the blood pressure. And mannitol, here, you'll be chatting with your neurosurgeon about how they want to use it, if they want to use it at one point. It does reduce your intracerebral pressure, but it is also quite a potent diuretic and can worsen your hypertension. So if you do have a hypertensive patient, you're probably going to be looking at hypertonic saline for the intracerebral pressure side of things rather than mannitol. Just in terms of anticoagulants, if the patient is known to be on an anticoagulant, it also puts them at a high risk factor for CT scans and imaging. If you do then do the blood work to see their INRs, their VT times, you can then make a decision on if you need to reverse it if the levels are quite high, and also in discussion with your neurosurgeons. Anticonvulsants can be considered. They say about 5 to 15% of patients with severe injuries or moderate injuries can progress to seizures or post-traumatic seizures. Phenytoin is your drug of choice, a dose of 20 milligrams per kg, and then benzos are needed to abort seizures. Don't give it, again, sort of empirically, rather just give it if there is a seizure and you need to abort it, because again, if you now worsen the GCS with a sedative, you're not sure where you're going with the clinical picture. So the mild hinder injuries is, as I said, the more common one. About 75% of the cases in the emergency room. More often than not, it's parents bringing their child from a head injury. They just want some reassurance that their child's going to be fine, that there's not some severe injury. Usually it's reassurance, symptomatic management, counsel them on the concussion symptoms. There's nice head injury forms out there that you can give to patients that have got concussion advice, red flag advice, when to come back. And then I'll talk about the return to sport later. We generally try to take a much more conservative approach, just because brains are more sensitive to injuries. If you can, they ideally want to be resting until they're completely asymptomatic before they go back to sports, because getting a second concussion when you're still recovering from the first one, the symptoms are generally more severe and give you more chances for longer permanent deficits. So yeah, the monitoring for at least 24 hours, but this, as I said, can be the caregiver if everything otherwise is fine. If you've decided you didn't need to do the CT scans, and generally the pain med of choice is just some paracetamol. You want to be avoiding your ibuprofens and your anti-inflammatories for the theoretical risk of an increased bleed, but that's usually just for the first 48 hours. So concussions, estimated to be about 2 million children and teens a year. It's often overlooked. People often underreported. Kids will often take a knock on the field and just try and continue playing. They'll have a headache and say, no, it's fine. I'll just kind of manage it myself. As I said, the second concussion is quite a top priority because the second injury is quite worse. Gradual return to activity. We don't need to restrict their daily lives. So people often think they need to now sit in a dark room, turn the lights off and wait until the headaches go away. They've actually found that this is more detrimental and symptoms last longer if you restrict their normal activities. You can let them go back to normal cognitive functions, maybe after a day or two. But if they do start to get any sort of symptoms with focus or cognitive activities, let them just take a break, a 5-minute break, look out, stop straining the eyes, and let them try to go back as needed. Patients are allowed to sleep. One of the common things people always think is, no, is it fine for them to sleep? Can I let my child sleep? it is allowed. The problem is if there's difficulty with rousing the patients, that's one of the danger signs. But yeah, they're allowed to sleep. There's no need to keep them awake for 48 hours. And yeah, there's the anti-inflammatories. The chronic traumatic encephalopathy there was a movie made about it. It was quite a big thing in America with the American Football League. All the findings, I think, were based on post-mortems of NFL players. So there's a bit of controversy around it. But the argument was that repeated brain injuries is causing significant neurological dysfunction in these high-level athletes and boxers specifically. So they wanted to try and find what could potentially be the cause. This was a name that was thrown out there, but essentially as if you just try and avoid a second concussion to try and avoid any sorts of these symptoms. So this is a bit of an evaluation form that first aids and sports evaluators would have on the side of the field. It's a sideline evaluation for immediately after the injury. Again, with anything concussion related, a baseline test is ideal because you can score this and a patient might not be great with their digit count backwards or their word recall. But if that was how they were at their normal baseline, then that's great. So it just goes through their orientation, some word recalls, some neurological screenings, concentration on counting digits going up in orders and of difficulty, month order reversal. Once you get to the exertional movers, if everything else is fine, you can then let them do that. The word recall is going to come back now here once they've done all of these jumping jacks, and it gives you a nice little score. Which, as I said, using in isolation is not great, but if a patient's had one of these, so this is where school programs do become quite important. Most schools that have contact sports, I think, should have some sort of concussion program, where if people are going into this just at the beginning of the season, should have some sort of baseline evaluation so that if these injuries occur, they can compare it and they can use it ongoing. This one is the post-concussion symptoms, so it's called a graded symptom checklist. It's about 15 to 30 symptoms that you can kind of use. Again, it's usually used at the time of the injury and then used to observe in the next 3 days. If your scores are increasing in any of these symptoms, it's likely that there is a concussion present, but it's a subjective evaluation that's based on the patient scoring between a score of 0 and 6, where 0 is nothing, 6 is severe. But usually then, as I said, it's used in conjunction with itself as to comparing to previous injuries. Usually post-concussion symptoms, it's worse in the first 7 to 10 days. Most resolve by 1 month, but you can get a post-concussion syndrome which lasts a lot longer. Some people are reporting more permanent deficits, usually not after the first concussion, but after severe head injuries or multiple concussions, they can. So this is a nice little thing about the return to play. So for the kids, you can just counsel them. If there was any sort of head injury, even if you're not sure if there was a concussion or not, I think this would be beneficial for most kids, just in making sure that they're fully asymptomatic by the time they do get back into their play. So the no activity, the recoveries for the first 24 to 48 hours, the physical rest, cognitive rest. So as I said, it's not complete. You can do some sort of normal days of activity, normal living. If there's no headaches for at least 24 hours, then you can go through to your light aerobic exercise. So walking, swimming, stretching, light warm-ups, getting your heart rate to, let's say, your target of 70% for about 15 minutes. If you can do this and you don't have any headaches for 24 hours, then you can go to the next step. But if you have any headache, you stop immediately, wait another 24 hours, and then try and repeat. Then the next step is your more like non-contact drills. So patients can start joining their trainings, they can do their running drills, their warm-ups, they're getting their heart rate a little bit higher for a 45-minute session. If there's any headache during any point of the exercise, they must stop, wait another 24 hours, go back to this step before, try see if they can do that, and then just slowly build on. Then this next step is non-contact training drills. This is where they get their heart rates more to the game level, the higher exertion for up to 60 minutes. Again, if there's any sort of symptoms, go back to the step before. If they're symptom-free for 24 hours doing this, then they can go back into a full contact. And for 24 hours, no headaches, then they can go through. Usually this is done over about a 2-week period. I wouldn't rush this process, especially in kids. I know everybody's very keen and the parents are eager to get their kid back onto the sport field, but you'd rather just take an extra week just to make sure the kid's properly asymptomatic and not at risk of getting another head injury that could potentially cause more significant problems. think that's it from my side. Thanks very much. Not sure if there's any questions.
Well, thank you so much. You always make it look so easy. You know, it's crazy. I think having concussion is something that you really, for me, I always say when a child got concussion or adult, it's like you have a closed book.
Yeah.
You actually don't know what's happening there. Sometimes CT scan might not reveal so much for you either. And sometimes it takes between 24 to 72 hours, depend what kind of bleeds you have, whether it's venous or arterial.
Yeah.
So sometimes we tend to, because the child can play and everything, we sometimes tend to jump to conclusion that everything's all fine. And I think for me, you highlight everything quite clearly. Now, the question is that any child with kind of injuries, is there a role from, I mean, most of them patients have seen casualty. I remember very well, there was one of our nurse that actually was involved in a motor vehicle accident, and she went to casualty to one of the hospitals, and then she was assessed and discharged. 2 days later, she developed, she became sick and died, and post-mortem, she had a massive splenic rupture. Okay, which was not evident before with point of care ultrasound. So the question is that, is there a role that these patients are actually followed up after when they have a major kind of obviously gradual injuries that they need to be seen 72 hours down the line, or you're comfortable when you assess them saying enough's enough, go home and you're on your own, because general practitioner might not have the skill and knowledge that you have?
Yeah, so follow-up is always good. Ideally, if you are ever concerned, you can always just schedule a quick follow-up. Even if it's not your same person in the unit, somebody will always be in your units just for a quick check-in. You can always do that. Yeah, that sadly, unfortunately, sounds like it was a multi-system injury where the severity was underlooked. So that patient probably could have had a discussion with a specialist to admit for observations. But often, as I said, head injuries, generally, this is a thing people worry about. And then you forget about the distracting injuries, the other injuries, because it's not, if you have a severe head injury or a severe mechanism, it's not just pressure to the brain. It's an injury to the whole body. And that's where you do need to make sure your clinical exam of everywhere else is fine. And if the original EFOS was negative, yeah, they potentially could have done serial abdominal exams and potentially a PAT scan.
Yeah, I think probably in this setting, education is very important. Because once the patient has an injury, it's always very important to educate the patient, and perhaps obviously, they could actually call.
Yeah.
Nowadays we have WhatsApp service, like communication, just to say how they feel the following day. Perhaps would be very nice actually to have that feedback.
I think we need to urge all doctors to use. Like we use a score for PEs and pneumonias. We use a score for head. The PECOs for the Canadian head injury. So the Canadian, they actually got rules for many things. The ankle knees, the rules, the knee rules, the neck rules, the head rules. Because resources are very limited in Canada. You can't just scan everyone, and they're much more aware of the radiation effect. So I think we need to be aware that we've had some complaints where the doctor scanned the patient and then they get the bill at the end of the day and they say, well, listen, was the scan justified because my child was fully awake and the bleakness wasn't that bad? And the doctor just scanned because it was a concussion. So the counselling needs to be there. The doctor needs to document that he's done the PECOs for his own defence. And then very important, I think we need to emphasise to people, here's the head injury sheet. But if you have any concerns, please bring back, because there's always a small risk of deterioration. But I must say, a problem for us is the post-concussion syndrome. In some cases, the post-concussion syndrome, can last for up to a month. And we've had the neurosurgeon's point of view is that they won't easily rescan within 2 weeks because of a post-concussion syndrome. And that creates a bit of a dilemma for us, because the patients then come back and they say they have persistent symptoms, especially if it's an older person. Yes. And then now the doctor calls the neurosurgeon. The neurosurgeon says, well, there's nothing to do. But then sometimes they make the mistake of calling the neurologist. And then they get upset because it's not a neurology problem. But then in elderly people, the one thing that we have to be, now you've got a pre-dementia patient with frequent falls. And now he's got some mental issues after the fall. Is it post-concussion syndrome, or is it his pre-existing condition now leading to the frequent falls? And I think there we need a sort of collaborative team approach to kind of sort these patients out. But they're not always that easy.
It's not straightforward.
Yeah.
I think just coming back to the spleen patient, I think in the elderly patients, it can also go the other way where the patient fractures the femur and the focus is actually on the femur and the head injury is actually missed or taken a backseat. And then I just have another question for you, if you know, does a concussion increase your risk of seizures later in life?
I'm not particularly sure with concussion. The resources there said it was more for your moderate to severe head injuries. Yeah. But they said it was still like a 15% chance of your post-traumatic epilepsy. I'm not sure specifically
And is
about
there any link
concussions.
to headache that you're aware of? Chronic headaches later in life?
So that's where it falls under the post-concussion syndrome, unfortunately. So they said most resolve by 1 month, but some can be permanent. Essentially, some people do complain of permanent deficits post-concussion.
But then, sorry, so what they say is that if you've got a concussion syndrome that lasts longer, so, you know, if it persists after 2 weeks, they actually need to do an MRI, not a complete scan, because it then is classified as a diffuse axonal injury.
Yes.
And those can lead to long-term complications, like seizures and chronic
That makes
headaches.
sense. And that's your answer to
Yes.
your question.
I think that's actually what I want to say. Yeah. So diffuse axonal injury is something that you might not see it on your CT or MRI immediately, but they will have long-term sequelae, you know, where they tend to have a lot of issues from headache to normal pressure, hydrocephalus, seizures, and all of the above. Yeah. So it's something really worth probably have a look, but also at the same time, you must just put in mind that patient that are involved with a concussion injury, they can also sometimes develop post-traumatic stress disorder. So sometimes you also need to allude to that and obviously look for the role of psychologists. I think that aspect also is very important. But those patients need long-term follow-up. The question that who follow up these patients? Are the casualty officers, I mean, else are not here to follow up patients. They this patient needs to be referred to a general practitioner. And the problem in South Africa, most of the general practitioners, they're jack of all trades, you know. But if you go to most countries, they're those who deal with like Netherlands, they'll be those neurologists, kind of inclined, exactly. And then the others are respiratory and all that. So I think perhaps in our setting, we need to start looking at actually once this patient being seen in casualty, emphasis must be made that they must visit their house doctors if they have any problems, you know, and that's really for me is very important. So that at least you kind of, and if you have given the patient that leaflets that you must visit your house doctors, and if you have any problem immediately, even from tomorrow to day after tomorrow, that actually decreases the risk of medical legal in long term. That at least now you have educated the patient, you have to sort out the acute process because that's what casualty does. Then at least now everything that happened for 48, 72 hours later should be attended by house doctor and obviously referral will follow up from there again.
I must say, in Canada, for instance, because the emergency department is so overloaded. They often encourage the patient to follow up with their GPs.
Yeah.
However, I find in South Africa, in general, if patients follow up with their GPs, the GPs sometimes
At the bottom.
we don't speak the same language, and then sometimes the GP has a different approach, and then there's some criticism towards the emergency doctor.
And that's a problem. Is that I've seen that is I think it's our problems and also university-based kind of training. And they never appreciate that. That's how always in my practice, I accept every patient and I never really question any GP or whatever is there because the reason that you just have to assume that they have tried their best and it's really not worthwhile to criticize your colleagues. Anybody online that want to ask questions, burning issues, comments or something? Thank you.
Just put up your hand if there's anything.
I must just say the one thing that in your severe head injury, hypertension is the one thing that should be avoided.
Hypo. Yes.
Because if you're, you not said below 100 systolic.
Yeah, as I said, the target was 100 for your more like 15 to 60-year-olds who have a bit more of a reserve, with a higher risk targeting 110.
Yeah.
Because over a period of
What's a map?
No, systolics.
Systolics.
Yeah.
It's quite low actually.
Yeah. There's, because they say you don't want to push too much if there is a bleed, I guess that permissive hypotension. You just want to keep cerebral perfusion. Yeah.
Too far, maybe more.
Even the brief period of hypertension increases your mortality significantly.
Yeah.
And quite often, when you're a period of intubation, if you give now a lot of drugs to intubate the patient, you can get a hypertensive episode afterwards.
Yeah. So I think that's why they use the etomidate and kits instead of like propofol.
So guys, thank you people online. I see that the number is really very good, 92. Please do subscribe to our YouTube channels so that, and please, if possible, spread the word out there. Let's keep the platform really as live as possible. We have a presentation every Wednesday also. The link remains the same. The link today is a link for every day on for the next few years. We're not changing it again. So if possible, please subscribe to our LinkedIn and all those. Let's share. And please, if you also have, you want to present, please, for emergency medicine, speak to Danny, and they will put you on the to present on the platform, because we want to give people voices. We want to hear your voice. We want to hear your knowledge. You know, we use all these things so that we can learn. So please, let's work together. Let's try to improve the platform. Thank you. Any questions?
The Wednesday talk is also 7 to 8 a.m. But exact same link.
Yeah, no, very well. You have said everything. Thank you. Thank you.
Thanks, everyone. Have a good day.